Today I'm gonna talk about about the ethical dimensions of artificial intelligence in nursing. As Siobhán mentioned, I'm professor of nursing at Yamaguchi University in Japan, and also the editor-in-chief of Nursing and Health Sciences. And my background is especially in bioethics, in the field of bioethics, so combining philosophy with nursing and health sciences in general. I want to start today with this quote from Cedric Price, an architect in 1966, just to call your attention. He said, technology was the answer, but what was the question? Yes, I want to share that because sometimes it seems that there is a lot of progression in AI tools, AI technologies, because it's somehow possible to do a lot of new research and new advances. But sometimes we maybe lose what was the question, the original question, the problem that we really wanted to solve. And especially this happens sometimes in research, in the area of research. So it's always important to think about the last question, what we really want to solve or to progress through the use of AI tools. In very brief, I'm going to talk about ethics. So ethics is a branch of philosophy, as you know, that concerns about questions of right and wrong, what is good or what is bad, questions of justice and fairness. It helps us navigate complex situations where there are competing values or interests or practices. Sometimes some ethical problems can overlap with legal issues, but they are not always the same. Sometimes ethics reflection or discussion goes on one way and the law regulation is maybe slowly, or is the contrary. The law appears first and then the ethical reflection comes. Today, I want to share with you some of the main ethical challenges in AI tools. And I want to also call your attention about these so-called empathic chatbots and finalize with some algorithmic paternalism comments. But before that, I want just to share some reflections about the datafication of health. Just in very brief, it's estimated that hospitals collect a massive amount of data, but only around 3% of the data they use. So 97% goes unused. This is according to Microsoft. If we reflect about the datafication of health, we can understand that we are now in a kind of data epistemic culture, which means that we are shifting into how knowledge is produced and validated in healthcare. This shift is from relying on the clinical experience of healthcare professionals, and now we are relying on algorithmic evidence and statistical correlation from big data. Then we also have a culture of self-monitoring, where everyone uses wearable devices, apps, or trackers to collect data about their physical, biological, behavioral condition. And this turns their personal experience into quantifiable metrics. For instance, our experiences change. If we go out for a walk, previously we described the walk as an enjoyable path under the trees nearby the river, but now we just describe it as I completed 10,000 steps, yes, because now we are tracking that. Apparently, also, there is a view that algorithm or AI is objective and neutral, value-free. There are no values in the AI or algorithm. But this belief is not accurate because, of course, there are social, ethical, and human values that are inherently embedded in how data is collected, interpreted, and used, and how also this nurtured the algorithm in AI. So going into the ethical challenges, I'm gonna, well, first of all, show this image because when we talk about AI, of course, the universe of AI is so broad. We have different systems from natural language processing to robots or generative AI with language model or, a lot of variations. So sometimes it's difficult to really try to capture the main ethical challenges for most of these technologies. But in general terms, These are the main ethical problems or more than problem challenges that I would like to discuss today. Some of them are more traditional and others are more new, if you want. I will somehow share each of these aspects with some examples, some particular example. Of course, the most basic ethical concern is related to safety, the potential for harm from errors, even if it's a false positive that can lead to unnecessary procedures, or if it's a false negative that can delay diagnosis or treatments, has the potential to harm the patients, right? So imagine, for instance, an AI early warning system to predict the deterioration of some patients or some sepsis alert systems that can cause false positives. This can lead to unnecessary interventions such blood tests or invasive procedures, and also can increase the monitoring of these patients. This can cause also anxiety for the patient and their family, and this can also lead to alarm fatigue in the nurses and in the staff treating this patient. And at the end, the alarm fatigue can potentially reduce attention to real emergencies. So these all have a lot of additional concerns. The second ethical aspect to consider is the reliability of the AI tools, the model generalization. Sometimes some models fail unpredictably in new or real world clinical settings. Imagine that we have an AI fall risk or pressure injury prediction tool that has poor performance in rural or underserved settings because the AI model was trained using data from a large urban hospital. And when we try to apply this system into a rural area, it has a poor performance. Maybe because the setting has different staff ratio, or because the patient demographics are different, or because the documentation practices in the hospitals in the rural area are just different from those in the urban areas where the model was developed. Then the next ethical challenge is about responsibility. So who is accountable for an error? Determining sometimes the liability when a patient is harmed due to a flawed prediction is an ethical concern. We understand in general terms that the AI tools support the healthcare professionals' decision making, but this needs to be clear, and everyone needs to somehow have a clear idea about that. Imagine an AI-driven clinical decision support system that makes some mistake and recommend, makes an error in the recommendation. So if a nurse follow an AI recommendation that turn out to be wrong, who is responsible? Is the nurse who made this decision, or is the AI developing system? Is the hospital manager who somehow purchased and introduced the system into the clinical workflow? So this is an important ethical concern. The other ethical aspect is related to explainability. Explainability is the ability to understand and interpret how an artificial intelligence system arrived at a specific decision. So it's what we usually call the black box problem, right? The lack of transparency in the decision making, how the system arrived to a specific decision is what we call the black box problem. So if nurses, clinicians, or patients cannot understand the rationale behind a high risk score, this raises some concerns. In general, in AI systems, there is a tension between explainability and accuracy. Ideally, we want to have high level of explainability and high level of accuracy. This is a perfect model. But this sometimes is not possible. And what happens most of the time is that if we have higher explainability, we have sometimes to sacrifice some level of accuracy. Or the contrary, if we want to have more accurate systems, it's at the cost of sacrificing some explainability. So Some years ago, we worked on this article to explore this problem in some specific AI-based medical decision making regarding resource allocation. And we somehow conclude that not all the kind of justice, when we use the term justice in healthcare, is not always the same. Sometimes we put more value on accuracy and other times on explainability. So accuracy serves what we call outcome-oriented justice. We pursue the maximization of the benefit for the majority of patients. For example, if we want to have an early detection program, a screening program to detect patients who can have cancer, we are maximizing the benefit for most of them. So we need accuracy. But when the decision is, we need explainability because it serves procedural fairness, which is other type of justice. And procedural fairness ensures that the decisions are non-arbitrary decisions, are justifiable, and follow some rationale. This is important when we are talking about the scarce resource allocation. So in cases where medical resource allocation, for instance, we use the example of liver transplantation, AI systems to predict or to decide who are the candidates to receive a liver, we need to have procedural fairness in these cases. And in these cases, explainability is totally required. It's an ethical requirement, even if it's accepting that there is some reduction in the absolute accuracy. So the decision sometimes between explainability or accuracy depends on whether the tool itself follows an outcome-oriented justice or a procedural fairness. When it's about resource allocation, we need to prioritize explainability because we need to know the reasons behind these decisions. Another ethical aspect is related to privacy. We are, most of us, aware of it, protecting sensitive health data from breaches or re-identification. This is one of the traditional ethical challenges. If we imagine an AI clinical or genomic data platform that for some breach in the data, permit the re-identification of patients and their families, this can cause serious risk for the patients. We need to ensure that the privacy will be always protected. The next problem or challenge is the consent. When we use AI system, we need to have meaningful informed consent for the present and future use of data. This is really important in both in research and also in the clinical course of our patients. So imagine an AI risk prediction model that the patient consent to provide their data, his data or her data for this model, but then these data are used for other secondary use. And the patient didn't consent for this secondary use. So this is a problem, but also the problem of whether the patients should know or should decide if they want to be somehow, if they want to incorporate the AI decision tools into their clinical course. Has the patient right to decide whether they want to, let's say, opt out of these systems? Or can they do that? Should the healthcare professionals inform always the patient when they are going to incorporate some tool for risk prediction? This is a kind of hot topic nowadays, and still we need to have more kind of international agreement on that. This is a recent published article which raised this concern about the AI informed consent. This is from some authors from Australia. I invite you to read it. And somehow they propose some strategies for redesigning informed consent forms when we incorporate the AI tools. Of course, using plain language, visual aids, and personalized information to improve the patient understanding, provide detailed explanations about the AI's decision-making process, limitations and the potential risks, and ensure transparency around ethical and legal aspects like the data privacy or algorithmic fairness. And then also how to implement and evaluate this framework, developing the consent forms through collaboration with stakeholders. This is really important. We need to incorporate the views of all the participants in any activities, the nurses, the patients, the doctors, the families. And it's also important to train the healthcare professionals on effective communication about the AI technologies, how they should provide this information about the use that they are doing for these AI tools. And integrate the technology to enhance the consent process and enable continuous monitoring and feedback, and evaluate the impact on patient understanding, trust, and decision making. Another ethical challenge is related to justice and equity. This is about algorithmic fairness. As we know, AI systems can have bias, and this bias can lead to unequal care. Training data is, if the training data is not representative of all the demographics. So you imagine that we have an AI fall risk prediction tool that is trained predominantly on affluent patient data and systematically underpredicts fall risk for lower income minority groups, leading to some delay or inadequate preventive care for these patients. So we need to ensure first know where the data come from, and then ensure that this data try to represent all the population that will have some benefit from the use of this AI tool. And then regarding the access and resource allocation, there is some disproportionate availability of advanced tools. We have some risk that only high resource private clinics can afford AI systems, while low income public hospitals, even in the same area, must rely on older or less accurate methods. And this can widen the health equity gap. I also want to share these concerns that we have now about the digital determinants of health. I'm sharing the WHO definition of digital determinants of health as any factor rooted in or contingent on the digital world that can directly or indirectly influence health or well-being. Similarly than what happened with the social determinants of health, now we have this digital determinants too. The technology is becoming more deeply embedded in our daily lives, and the digital determinants of health can affect existing relationships between social, political, or commercial determinants and health, and create entire new ways to influence the individual or population's health. We recently published this article about the data governance and the interest of the global community. In the light of the new European Health Data Space Regulation, we underline the need for interoperable electronic health records, reuse of the health data for research and innovation, and the patient access. Because, with the digital tools, the global equity is at risk. We have digital divides and health data disparities, and this may reinforce rather than reduce inequities. So in this article, we propose data cosmopolitanism as a normative concept where data should promote global solidarity, justice, and shared benefit, not just national competitiveness or commercial gain. So for digital health to truly improve health equity, governance must attend to who owns the data, who benefits from this data, whose voice is heard, and ensure that digital infrastructures do not become new axes of disadvantage. And the last topic that sometimes is not considered enough is the sustainability. We can have a lot of advancement in AI tools, but if it's at the cost of some environmental impact, maybe this is not what we want from the ethical perspective. So one of the aspects is the environmental impact. All these technologies have some environmental cost because they use a lot of energy and require, a lot of consumption. Imagine the next generation of predictive models that can generate a carbon footprint, maybe equivalent to a family taking multiple round trips flights across a country. And one of the problems is that we lack really monitoring systems to track the impact of this AI training system or the development of these AI systems. There are very few reports on the environmental cost of these technologies, and it's something that we need to really try to improve the transparency about the environmental cost. And then the problem of the sustainability, the systemic viability of these systems. We need to ensure the systems remain effective over time, because many times there is a lack of standards or poor interoperability and high ongoing costs that can make AI systems unsustainable or abandoned over time. So the AI models maybe relies on an outdated data format that the hospital's new electronic health record system no longer supports. The model becomes obsolete within 2 years because the hospital cannot afford the continuous maintenance and retraining required. So this is a problem that we need to consider because we are sometimes investing a lot of resources and money in creating and introducing new systems that maybe can be obsolete in a couple of years. I also participated some years ago in this article where we somehow question this idea of the tension between AI technology, the environmental cost of AI technology, and the environmental justice. So, of course, using AI system in medicine and epidemiology has a lot of benefits in the short term, if we think in the short term. But also by using AI, we can cause social inequalities and environmental damage in the long term. And this has effects in the health of the population as well. So if we think in terms of health justice, we should rethink from the perspective of the One Health paradigm, going beyond the anthropocentric and myopic cost benefit analysis to expand the health justice to include the environmental dimension. And of course, greening AI would help to reconcile these public and global health measures. Well, this is all the kind of landscape of ethical challenges. And now I want to call your attention on empathic chatbots. The first question that appears is, would AI replace healthcare professionals? This is a question that is somehow always around. We expect not, because there is always a shortage of healthcare professionals, and we want to have and create AI tools that help us to do our work. But the risk is there, as we are seeing in other areas. People can be fired if AI replaces some workers. So the risk is that sometimes some AI tools can maybe lead some policymakers to make wrong decisions about replacement. But well, we hope this doesn't happen, at least not in the near future, but it's a risk. Other than that, I want to call your attention on empathic AI, because recently we have a search of AI chatbots in healthcare that prompts big claims about empathy, care, and human-like support. This is one example. And in this article published in JAMA, the researchers, the question they had was, can an artificial intelligence chatbot assistant provide responses to patient questions that are of comparable quality and empathy to those written by physicians? So just by asking the question, we have some problems, because empathy is a relational, moral, and embodied human practice. It's not just comforting phrases or tone. So these large language models can produce simulations of empathy, not genuine recognition or responsiveness. But the problem, and we highlighted this recently in the editorial that I shared in the screen, on the screen, and the risk is that this creates some conceptual confusion because we are misusing thick moral concepts like empathy or care. And language is word making. When we call AI empathic, then this idea of empathic AI is around in the society, and the public start using these words. And this reshape what the public or the society in general, and also healthcare professionals, consider adequate empathy. And the risk is that the simulation becomes the new benchmark, and this can lower the expectations of real human empathy. So we use in this editorial two examples. One is the use of personal voice assistants to reduce loneliness in older adults. There are, well, certain amount of research on this topic. These studies show that individuals with higher initial levels of loneliness were more inclined to interact with voice assistants in human-like ways, which appear to alleviate their feelings of isolation. The main ethical concern is that this may be an adaptive preference, which is a coping strategy under deprivation rather than a genuine improvement in well being. So, even if voice assistants can mimic companionship, they cannot address the deeper social, psychological, and structural causes of loneliness. And the problem is that, we are maybe we are becoming, this is becoming a deformed choice. Um, we are giving them sweet lemons, but not the strawberries they want. You know, the way to solve loneliness and isolation in older adults, maybe we are not going on the right direction if we try to give them personal voice assistance. Maybe there are other ways in which we can try to reduce their loneliness, and they will have finally companionship. That is what they want, not a simulation of companionship, which never will be the strawberries that they want. In the second example, we analyze generative AI for diagnostic dialogue, AMI, a large language model based diagnostic system. And this system is designed to engage in diagnostic dialogue, showing superior performance compared with primary care physicians across some evaluated clinical and communication metrics in controlled study with patient actors. So, of course, this has some concerns about moving from simulation to the clinical real setting regarding safety, fairness, reliability, and privacy. But one of the main problems is the automation bias. The healthcare professionals, when using these systems, may defer to AI, even when their judgment is correct. And this can affect both novices and experts. And one of the problems is the de-skilling. The long-term reliance on AI may erode clinical skills like history taking, diagnostic reasoning, communication, and other skills. So even if a highly effective diagnostic AI tool can weaken the professional competence and at the end endanger patient safety if it replaces, not supports the clinical judgment. So that's why it's so important that we emphasize all the time the role of the AI tools as supporting the decision making of the healthcare professionals. So technology is not ethically neutral. AI systems always have different effects. They can reshape practices, expectations, and relationships. And generative AI may serve, of course, auxiliary supportive roles, such as reducing administrative burden, enhancing training and education, improving documentation and workflow, but only if its use restores time and attention and moral space for genuine human connection with the nurses physicians. The last point is about algorithmic paternalism. The last century, the 20th century, is remembered for the efforts to overcome the medical paternalism. But now in the 21st century, the healthcare institutions are facing a major challenge, which is the algorithmic paternalism. So if we somehow imagine in the past century, we were in the paradigm of medical paternalism, where the doctor had all the knowledge, they have all the knowledge, and the patients somehow were obedient to the doctor's decision. But this, of course, changed over time. The development of bioethics was related in many sense with this, and providing more awareness on the right of the patients to make decisions and to actively participate and decide about their health. Now we are in the under the paradigm of the patient-centered care, where the healthcare professionals have some knowledge, they share with the patient, and the patient values, expectations, religion, all what they consider important is taken under consideration in the decision making. But now the problem is that we are turning towards algorithmic paternalism, where the healthcare professionals rely on the algorithm, and the patient also rely on the algorithm. So where is the patient's values or the healthcare professional's expertise or experience is somehow unclear. So this is the new challenge. When we somehow introduce the new agent in the decision making, the algorithm, these systems can guide, restrict, or sometimes even override the human choices. It shifts the power from the healthcare professionals to the algorithm, or from the patients to the algorithm. And sometimes without transparency, as we saw before, or consent. And this can recreate the same kind of paternalism that bioethics originally sought to reduce. So if we think about that, is algorithmic paternalism in healthcare always wrong? Well, it depends. It's not inherently good or bad, but the ethical acceptability depends on how much it affects the human autonomy, whether users consent and are aware of this paternalism, and whether the intervention is proportionate to the risks involved. So there are also some degrees of paternalism that varies from soft guidance to moderate or strong restrictions. For instance, if we think about soft paternalism, these are guide choices. For instance, if we have a virtual medical assistant that advise whether to see a doctor or not. Then we have other tools that can restrict choices, which we call moderate paternalism. For instance, digital triage tools that restrict appointment booking unless certain symptoms are reported, to, for instance, preventing low-risk patients from scheduling urgent consultations. And then we have strong paternalism when the system overrides or blocks choices. For instance, if we are using some risk scoring tools that need to justify overriding or diminishing alerts. For instance, for risk score for infection or risk or sepsis, right? So we can add an additional problem. Imagine this is a situation that you are a 30 years old person, and you return home after a stressful day at work, wishing for a long bath to relax. After soaking in the tub for half an hour, the alarm suddenly goes off and your phone starts ringing. Your family members have been alerted by sensors in your home that you have been in the bathroom for longer than usual. Once the situation settles, you head to the kitchen to have a glass of wine. only to receive a message on your smartwatch warning against it. Your digital assistant reminds you that you've had wine in the previous days, which is very bad for your health and may affect your life insurance. You are advised to return the wine to the fridge and head to bed. Otherwise, your family and physician will be notified. This is a kind of horrible scenario if we think about that, far from what is desirable. But when we change the main actor and we put an old man in their 80s, an 80 years old man, the story changed. And this is a concern. I took this example from this article here from Cristina Boinea and colleagues. And this raised concerns also about ageism, ageism and AI. As you might know, ageism involves stereotypes portraying older adults as frail, vulnerable, or incompetent, which can harm their autonomy. These stereotypes are often internalized and reproduced in the technology development unconsciously. When ageist assumptions shape AI for age care, they result in technological paternalism, technologies that know better and constrain older adults for their own good. So, how AI embeds ageism in the designer's assumptions about the typical older adults as incompetent, passive, fragile, this become embedded in the scripts in the technology development. In addition, older adults are usually excluded from the design process, and this can lead to technologies built on their behalf, but not with them. And technologies most of the time prioritize safety over autonomy. And this can be influenced by the preferences of the family or the institutions, but not by the user's preference, especially if the users are older adults. So I just wanted to call your attention on this problem of ageism too. And the final remarks, because, with all of this landscape of ethical issues, there are, well, still so many things that we can do. These are just some recommendations. We have to think about participatory design every time, involve stakeholders when possible in the design of the AI tools, including the end users, nurses, physicians, patients, families, through the development to avoid biases, stereotype users, and to really respond to their needs. Address data bias, improve inclusion, disaggregation, and representation of the population is really important. Pay attention to the data governance, international global regulation to promote the digital equity. And finally, AI literacy, avoiding framing AI as all-knowing, which can fool this algorithmic paternalism, incorporate the patient experience and wisdom, and promote critical thinking and clinical reasoning. And I have to say that in this regard about AI literacy, I do believe that the AI Nurse Network is doing an incredible work to promote AI literacy among nurses all over the world. And this is a really important and necessary, really necessary work. Thank you so much. That's all from my side. I will be happy to be in touch with you if you have some interest in some specific aspects. Okay.
Super. That's great. Thanks so much, Janet. I just have a couple of questions before we finish because there was lots of really interesting ethical points around AI. So I was just wondering, how did you get started in AI in the first place? What was the interest for you?
Well, in fact, when I first started my journey into ethical aspects of AI was during the COVID pandemic at the beginning. At that time, I was living here in Japan, but I had connection with a network of scholars from Spain, from bioethics. So we started having some kind of spontaneous community of practice where we had regular meetings once a month or something like that to discuss about, all the ethical concerns arising at that time. And within this a group of scholars, we started somehow having more interest in the AI tools developed for the COVID-19 pandemic. So we applied for some grants to address the bias that some of these tools, especially tools used for triage or for tracing or surveillance of patients who have COVID, can have. And then, of course, after this first research, just my interest was increasing and increasing, and we started navigating into additional ethical concerns on AI.
Yeah, yeah, that sounds great. Yeah, there's so many issues to do with AI, both positive and negative. So, um, what advice, I guess, would you have for other nurses who are maybe curious about AI and want to do a little bit more work in it?
Well, I don't know. I think my main recommendation would be to always remain critical and have critical thinking about AI. You know, don't assume AI as all knowing, as I highlighted,
Mm,
trying to really understand what's behind the decisions provided by the AI systems. Try to be curious to really explore whether the users have been involved in the design or not, how these AI tools can be improved, how we can enhance the transparency and the trust on these systems, but always with a kind of critical thinking voice with them, no? Because it's
yeah,
quite important to have
yeah.
this vision.
Definitely, it's a good advice. Lovely. And my last question's a little bit difficult because I guess we're all trying to speculate about where AI might go in the future. But yeah, do you have any kind of thoughts around maybe some of the ethical issues that might crop up with AI in the future if it continues to advance?
Well, of course, I think these issues about how we incorporate the AI in the decision making, how we incorporate the patient's consent and their knowledge about whether or not we are using an AI system to treat them is a quite important topic. But I really think that AI has potential to improve many areas and enhance the quality of care. Of course, in remote areas, we have to really somehow focus on this, how the AI tools can um, decrease inequities, not increase them, but decrease, especially in rural areas or remote areas, how we can support these patients better through AI technology. I also believe that AI solutions can help a lot to improve in the future cross-cultural healthcare. You know, we have a lot of issues sometimes treating patients from different cultures in our healthcare systems, and AI has a lot of potential to support healthcare professionals and the patients to navigate these cross-cultural differences in a positive way. I think so.
Great, brilliant. Well, thanks for a wonderful presentation, and we're looking forward to hear more about your research in the future.
Thank you so much for the opportunity.